Patient SK presented with increasing shortness of breath, right-sided chest pain, productive cough, and a change in her level of consciousness. She was febrile with an O2 sat of 83% on room air. She had an elevated white blood cell count, and on chest x-ray there was a consolidation. SK was intubated and transferred to the ICU. Blood cultures were sent and antibiotics were administered. She is diagnosed with community-acquired pneumonia, or CAP. In Canada, pneumonia, including influenza, is the 8th most common cause of death. A third of patients with CAP are admitted to the ICU, where mortality rates range from 20 to 50%. Like all pneumonia syndromes, the diagnosis is based on the appropriate constellation of clinical signs and symptoms. Blood and sputum cultures should be sent for any patient with CAP sick enough to be admitted to the hospital, especially the ICU, but they are often negative. Therefore, antimicrobial therapy is often empiric for the entire course of treatment. It is important to target therapy to the most likely pathogens, current resistance rates, and, where known, recent antibiotic use. The key pathogens to consider in CAP include Streptococcus pneumonia, Haemophilus influenza, and in the ICU, Legionella species. Staph aureus, or methicillin-resistant Staph aureus, MRSA, should be considered in a patient with known colonization or risk factors. During flu season, influenza A and B are notable causes of pneumonia. Surveillance systems routinely monitor resistance in strep pneumo and H. flu. Current macrolide resistance in strep pneumo is around 30%, while penicillin and cephalosporin resistance is less than 1%, and fluoroquinolone resistance is between 1 to 2%. Outpatient rates of ampicillin resistance in H. flu are roughly 18%. Therefore, for SK, a reasonable choice would be a third-generation cephalosporin, such as ceftriaxone or cefotaxime, plus a macrolide, like azithromycin. The third-generation cephalosporin will cover strep pneumo, H. flu, and gram-negatives like E. coli or Klebsiella pneumonia. The macrolide will cover Legionella. During flu season, consider adding oseltamivir. Guidelines recommend either a macrolide or fluoroquinolone for severe CAP. Using a macrolide where possible will avoid the overuse of quinolones, which are a risk factor for the NAP1 strain of C. difficile. If a bug is identified, tailor the antibiotics to target it. Regardless, 7 days of therapy for patients with CAP, even those in the ICU, is sufficient, unless there are complications like Legionella or Staph aureus bacteremia. Key messages: target the most likely pathogens. For most patients, choose a third-generation cephalosporin plus a macrolide, and treat for 7 days.